Welcome to EPG Pathshala. I am Purendra Prasad, working as professor in the Department of Sociology, University of Hyderabad. Today, we will be talking about rural private practitioners in India. This is the module number 10 in the Sociology of Health course. Rural private practitioners actually are called RMPs. RMP actually has other kind of a connotation, registered medical practitioners. The government actually recognizes the doctors who are trained for a period of 5 years and have a formal degree are recognized as RMP doctors. However, in the Indian context, RMP is also used in a colloquial sense, that these are the doctors with formal or informal kind of a training that they received. When we say formal medical training, it need not be only allopathic medicine. There are several of them who are qualified Ayurvedic doctors, Unani doctors, homeopathy doctors, but practice allopathy in rural areas. So, there is a wide range of rural private practitioners in the Indian context. And why is it that we find rural private practitioners in India, despite the fact that we have primary health centers in rural area, sub-centers run by the paramedical staff, you have Anganwadi workers, ASHA workers, you have community health volunteers, multi-purpose health workers. So, when there is a whole lot of trained medical personnel in rural India, why is it that rural private practitioners exist? In answering this question, I think we need to go back saying that the very concept of public health care in India actually as a public good emerged immediately after independence. Government of India, based on Sir John Boer Committee recommendations, implemented primary health centers, sub-centers, community health centers and the district and state tertiary hospitals across the country. However, these trained medical personnel who are supposed to cater to the needs of the rural population have not been able to provide the services that is required for the entire mass of people in India. Therefore, in order to supplement the government health cadre, private health care practitioners actually emerged. Of course, before independence also there were private practitioners. After independence, the private practitioners, largely the allopathic trained doctors emerged in the early decade, while in rural areas there were traditional practitioners who are either qualified or not qualified, but practicing either at home or dispensing in a small kind of a clinic, etc. But by 1970s, when the euphoria that government healthcare system will be able to provide services to all the citizens of this country actually failed or had limitations, then the private practitioners actually became rampant. So, in 1971, as Newman and others say that there are different regulatory systems in India in terms of, or different classificatory systems in terms of categorizing the practitioners. One set of doctors who are formally trained MBBS doctors with 5 years of their degree and further specialization, they actually they register under Indian Medical Council, and therefore they are formal trained doctors. Second set of categories who are called traditional practitioners, who also enroll with the government and they are allowed to practice. Third set of people who are called enlisted practitioners, who are supposed to be the RMPs, who qualify in terms of their degree or diploma for 2 years and adequate number of years of hands-on experience as a doctor, then they are actually given the permission to practice medicine. But these three categories is something that is a very formal and legal framework. However, lot of empirical studies conducted in late 70s and early 80s by scholars such as Mark Nichter and others clearly indicate that this is not the classification that you find in rural areas. Rural private practitioners means that anyone who actually have knowledge about practicing medicine are able to set up their own clinics in rural India and have been actually going about their work. So, if you look at the formally trained Ayurvedic and Unani and homeopathy and other alternative medical systems who have set up their own clinic but practice allopathy, this is based on their hands-on experience in one of the small nursing home or the clinic. So, it is some kind of apprenticeship in terms of working for some time and then setting up their own clinic. Second set of people who also actually work with not formally qualified practitioners, but they also based on their experience they come back and set up the clinics. There are compounders, pharmacists and other kind of cadre of health personnel working in different private clinics actually with very little knowledge also try to establish a private clinic in rural India. Now, the question is, while there is a huge kind of a range of these doctors in rural India who are not qualified, so do we need to actually say that unqualified practitioners actually are the ones who are practicing in rural India? Yes, Rode and Vishwanathan study, Mark Nichter study does indicate that it is a large majority of unqualified private practitioners who are actually practicing in rural India. Why? Why do people actually approach these not qualified practitioners when there are qualified practitioners both in government and also in the private sector in urban areas? The reason is that over a period of time, 50s and 60s actually is considered as the golden age of public health in India. That's the period where there is a lot of investment that state made and tried to implement the healthcare services in every nook and corner of the country. But by 70s, the credibility of these the public healthcare system actually came down. The state started actually also withdrawing its resources and its commitment towards the public health the way it visualized in the early 50s and 60s. So it started encouraging the private practitioners in different regions and different areas in the states. And therefore, on the one hand, you have public healthcare which is not a reliable and stable kind of a healthcare system. On the other, you have qualified medical practitioners working in private sector, but none of them actually want to locate themselves and practice in rural areas. As a result, there is a huge void in rural areas. Neither the government healthcare system is effective, nor the qualified private practitioners are willing to actually provide services. As a result, a large number of rural private practitioners who are quote unquote called as quacks, quote unquote called as unqualified practitioners, started their own kind of practice. So this is the kind of a paradox where we see that India actually is becoming a destination for medical tourism. A lot of corporate and tertiary hospitals, both government and private, actually are able to provide the best of the services actually in healthcare sector. Therefore, a lot of people from different countries actually are coming to India for treatment because it is reasonable, the services are very efficient, and it is comparable in terms of the global healthcare system. While that is on the one hand, but if you look at the rural India, it is completely left for these unqualified practitioners to situate. Now, do we actually say that the rural private practitioners should be actually should be banned, should not be allowed to continue their practice because they do not have adequate and scientific kind of a training? Rode and Vishwanathan actually vehemently argue that we need to rather integrate them with the government healthcare system, and we need to actually bring them in terms of a kind of a complementary cadre of health personnel that would help not only in terms of equipping them with adequate medical knowledge, but also we can make them accountable to government sector. Now, this debate actually happened in 1980s, especially after emergency when Janata Party government came, when it's talked about people's government, Janata, and it also talked about in the health sector, people's health in people's hands. And this slogan actually helped them in terms of the central government mooting an idea that any graduate from a particular community can actually enroll themselves, do a 2-year kind of a licentiate or a degree, and then will be allowed to practice in rural areas. And this scheme actually continued for few years, and within no time Indian Medical Association actually lobbied with the central government, saying that this is actually introducing the quackery by the Indian state and legitimizing the process. And they were successful in actually getting the scheme actually quashed. After that, the rural private practitioners who are left with no training, no recognition, have actually been going on with their business. So, there are several kind of questions that I think come in here. Okay. Some of the civil society organizations and health activists have been arguing that providing primary health care does not require a qualified MBBS doctor. Second, even when these qualified medical doctors, MBBS and MDs are posted in rural areas, they are reluctant partners. They do not show up to the clinics. Their involvement and participation in the primary health center is very, very minimal. As a result, why are we not actually promoting, the paramedical staff or community trained health workers to dispense the medicines and do health care at the primary level? That actually is the justification for these rural private practitioners to be integrated into the government health care, as increasingly the state is withdrawing and state is not able to commit its resources to the health sector. Even today we have less than 2% of our GDP which is being committed to the health sector, while Bore committee and others actually argued for at least 5% of the GDP in terms of health care. So, given these kind of commitments, why not recognize these rural private practitioners and encourage them and integrate them? This is one of the major arguments. So, the entire dilemma here is not about qualified versus unqualified, it is about accessibility. Why is it that the poor laboring classes are not able to actually access the healthcare services that are safe and more appropriate? Okay. So, if you look at the rural communities and their preferences and the reason why they are actually approaching the rural private practitioners, it is because of the physical distance. Rural private practitioners are located right in their villages, in their proximity, they are available all the time 24/7. They actually treat them even without payment immediately. So, the possibility of paying later, the credit facility actually is encouraging them. Lot of women and aged and dependents are not actually able to go far distances, and therefore, rural practitioners become the mainstay of these communities. And they also feel that because rural private practitioners give injection medicine, which is the first level of treatment, so it gives quick relief. So, the assumption of the rural communities is that it provides quick relief, they are available and they do not actually ask for money immediately, and it is something that they can fall back without much of discomfort in terms of language or the dress and other set of behaviors. So, these are some of the reasons why rural private practitioners actually exist in India. I think instead of dismissing these rural private practitioners as quacks, one needs to carefully examine the underlying reasons and the way state actually is not regulating the private practitioners of any kind. It's not only rural private practitioners, even in urban areas, the nursing homes and the corporate hospitals actually are outside the regulatory kind of mechanisms. So, when it comes to the question of accountability, when it comes to the question of unethical practices, it is actually prevalent across the private sector. So, state actually is loosening up its kind of responsibility in regulating the private healthcare practitioners, because it does not actually affect its own class interests. And therefore, it does not have to spend any money for actually the private practitioners. It does not need to give them any kind of training for these rural practitioners. So, it is allowing these kind of practices to go on for several decades. So, as sociologists, we need to understand why people actually approach, access certain kind of practitioners, although they are not qualified. When several anthropologists and sociologists asked these communities, how do they actually classify these practitioners? Is it based on their formal qualification in terms of MBBS, MD? They all responded saying that no, it is about relief, it is about our perception of efficient treatment. So, it does not matter who is actually a qualified and who is not a qualified practitioner. What is important is to provide treatment immediately at their doorstep. So, these are the kind of dynamics that are available in terms of the rural and urban sector. Healthcare actually is the mandate of the state in terms of providing them free healthcare services, which has been actually accepted for several decades in India. Given the inequalities, given the kind of illiteracy and other kind of resource constraints that rural communities in India have, now providing the efficient and safe healthcare is something that need to be actually thought through more carefully. The expectation that state healthcare actually will be able to provide did not actually live up to the needs of the people. So, in that sense, while the issues of equity, social justice and providing including these communities into the healthcare services are some of the critical kind of ideas right from independence period. Today, when we talk about the kind of huge disparities where rural private practitioners have become the mainstay of the healthcare system, do they actually give enough kind of care and appropriate kind of a care to the communities? Now, that question about quality healthcare, okay, is something that needs to be integrated at a broader level. When the entire institutional structures actually have failed, what happens is the non-institutional mechanisms which actually are unregulated, and there is the last resort where people are made to actually go through these rural private practitioners. So, in a sense, when we are talking about what is actually desirable, what is prescriptive, what is proscriptive in terms of healthcare, it's easy to talk about quality healthcare and providing the kind of efficient and very appropriate kind of healthcare. But what is important from the community's point of view is that it also need to be affordable, it need to be available to the communities, it needs to be accessible to the communities. Okay, so these are the kind of paradoxes that the Indian society is facing, and instead of looking at the underlying factors why different set of healthcare systems actually are in place, what one needs to actually look at is how state can actually step up their investment in terms of healthcare to the tune of 5% of the GDP, equip all the primary health centers, community health centers and the district and state hospitals adequately, and also try and train a large number of healthcare volunteers and that of community health workers. If one could actually bring that kind of a system in place, then we do not actually require these unqualified practitioners, and I think unqualified practitioners also would be able to get absorbed into these cadre of health professionals, and that's not actually the situation today. Okay, left to the market, left to the individual choices. Okay, the discussion and debates are going on what is desirable and what is not desirable, and therefore I think one needs to look at the structures in which capitalist kind of accumulation processes which are promoting private healthcare and quality kind of interests in urban areas, leaving the rural population actually completely to completely out of this kind of ambit of quality. And it's interesting that today the corporate hospitals and the big kind of hospitals today actually use these rural private practitioners as referral centers whenever they actually get a patient who can afford. So those kind of patients are being actually referred to these corporate hospitals. So there is a kind of a link. The way corporate hospitals and private healthcare institutions have converted the RPPs or rural private practitioners as middlemen, again tells you the linkage in terms of their own profits and trying to satisfy their own needs rather than in terms of the community needs. So let me sum up. Given the collapse of or the limited kind of public healthcare system in India, given the skewed interest of the private sector only in urban areas, and given the commitment of all the qualified practitioners to be located only in urban areas, what leaves the rural communities is in terms of these unqualified practitioners. And if one needs to actually address these issues, there need to be a kind of a strong public healthcare system that needs to emerge in India that can actually address the concerns of the people and that can lead to progress of a nation.